Thank you so much, Mauro, and thank you for, I guess, kind words. I didn't understand completely what you were saying. I understood the pictures, and it's great to be back because indeed we started in 2008. Then when you visited and you showed the picture already, and you didn't show this one, but in 2019 we didn't only have the ankle course, but we also had fun, and we had Palmeiras win over Fluminense, so that's why we are cheering here. And I think here are you. This is my wife. This is your wife. So we had a really fantastic time, and then we decided to have a repetition of the course for 2020. But then COVID came, and then we were not able to have the course in 2020. So we expanded to this year, and we're here. We made it. Fantastic, and you made it. So I'm very happy. We had an intense program with 3 live surgeries and 3.5 hours of lectures. And it's interactive. So whenever you have a question, please interfere and ask me about anything that you want. So this is not like a typical conference in which you have debates, pro and cons. It's a concept which I developed and which I have experienced now for almost 40 years in orthopedics. So I will tell you about my experience, but also about the latest evidence. And I will just show you where that comes from. But my affiliations, my disclosures, I'm the editor-in-chief of the GISACOS, still for a few days, because I have been given over my position from next month onward. But I will still be involved, and I'll be happy to see your contributions to the journal. I'm consultant of APSurf and Smith & Nephew. So in the lectures, I will tap into this lecture that I was asked to give. It was a big honor for me to give the Einar Eriksson lecture. Einar Eriksson is the founder of ESCA, the European Society, Sport Traumatology, Artroscopy, Knee Surgery. And he is also the founder of the Case Journal. And once every 2 years, someone is invited to give that lecture. And I gave that lecture in May 2022, and they gave me the title, 20 Years of Innovation and Improvements in Treatment of Ankle and Hindfoot Disorders. So what I did to prepare for that lecture was to look into the literature. And since I retired from the university, I don't have residents that I say, look into the literature, and I had to do it myself. And that was wonderful. It was a wonderful journey doing this systematic review of the literature in all ankle pathology. It took me about half a year to prepare for that lecture. And what I was doing is to look, where do we come from with a certain procedure or a certain instrument that was introduced or technique? What has been the evolution, and where do we stand today? What is the current evidence? So I was looking for the most recent systematic reviews or meta-analysis. And if the last meta-analysis was in 2020, and there were still important randomized clinical trials, I was also adding them to this lecture. And whenever you see this red line in my in one of my slides today, it means that above the red line is what was the past, where do we come from, and below the red line, where do we come, or where do we stand today. And when I was looking through the literature, I came across, in the Journal of Arthroscopy, I came across this very interesting sort of debate between Richard Virgil. You all know Richard Virgil, the guru in the United States of ankle arthroscopy, and Jordi Vega. Jordi Vega from Barcelona. He will be giving a minimal invasive course in a few weeks' time, I believe, here in Rio, also. And it started with an editorial commentary in the Journal of Artroscopy, which was titled, "Distraction is the Key to Success." And that's indeed the method that Virgo always have been proposed to ankle arthroscopy. Jordi Vega, 1 year later, in the Journal of Arthroscopy, replied to this editorial commentary, "Dorsiflexion is the key to success." Where am I? And Jordi wrote, well, doesn't advance with this, correct? No, so I do it like this. Dr. Virgo's editorial commentaries negatively influenced the progress and development of ankle arthroscopy. Some major publications in European journals that support the dorsiflexion technique are ignored. In USA, ankle arthroscopy is performed with routine distraction, whereas no distraction and dorsiflexion is the commonest technique in the rest of the world. The dorsiflexion technique for ankle arthroscopy allows for new third-generation procedures which cannot be performed with routine distraction. So that was quite some text that he was writing in the Journal of Arthroscopy. But a few months later, in the Journal of Arthroscopy, Virgo replied, "They are dead wrong. They have not read my books and articles. The notion that my teaching is not third generation is ridiculous. In our courses, all techniques are taught, and we're excited that Van Dijk is one of our master teachers that year." And that was true. I was in US that year. The Amsterdam Foot and Ankle School courses have contributed greatly to the education in ankle arthroscopy worldwide. But in 2021, again, non-invasive ankle distraction is the standard of care for ankle arthroscopy, whereas in the rest of the world, the no distraction and dorsiflexion is the commonest technique. It was very interesting when I was looking through the literature to get to this debate. So let's consider the two methods. On the right, you see the ankle distraction technique. It was introduced by Jim Gould. I visited Jim Gould to learn the ankle arthroscopy. It was around that time. I was a fellow, and I visited him to see him do it, and then I thought, this is not working. And then I developed my dorsiflexion technique, which makes use of these capsular attachments, and when you put saline in the joint, the anterior working area opens up. And the safety of both methods has been determined in the lab, Pau Golano lab in Barcelona, and in dorsiflexion, the neurovascular bundle moves away from the joint, where in distraction, the neurovascular bundle moves towards the joint. And this was confirmed in a cadaver study. You see the red line? This is the 2018, the most recent study, that indeed the difference between the length, the safety zone is twice larger with dorsiflexion compared to distraction. What is important to realize that with distraction, if you introduce an instrument, the nerve and the vessels are like a string. So if you're on the nerve, it can easily break. In dorsiflexion, the nerves, when you move with an instrument on top of the nerve, it can easily move away. So I think the difference in complications, nerve complications, is related to the introduction of instruments. So the dorsiflexion technique means that the dorsiflexion position is for the introduction of instrument. Always when you introduce your instrument, go to the dorsiflexion position. But you can place distraction when needed. You can use this non-invasive distractor and use distraction with this method. So dorsiflexion to introduce the instrument, and then if you need, you can put distraction to go look at this osteochondral defect in the medial malleolus. If you then have to change, for example, for a shaver, go to the dorsiflexion position, introduce the shaver, and go back to the plantar flexion position if you want. That is how you manage this dorsiflexion technique. So it's not only dorsiflexion, it's only for the introduction of instruments and working in the anterior working area, but you can also distract when needed, and you can also plantar flex. And in plantar flexion, and you see it on this anatomical view, and also in this anatomic study in 2018, Hirtler showed that plantar flexion is equal to non-invasive distraction in reachability of the cartilage. So with the dorsiflexion technique, you can dorsiflex for the introduction, work on your osteophytes, impingement in dorsiflexion, but distract when needed. And when we look at the complications, then you see that with skeletal distraction, that was the time of Jim Gould, when I visited him, it was skeletal distraction, it was 13%. But with the soft tissue distraction, Virgil 9%, and you see here the studies, it is 9% complications, mainly nerve injuries. And when you look at the dorsiflexion method, it is only 3%. And a recent literary review confirmed that the commonest complication of anterior ankle arthroscopy is nerve injuries. So let's look at the Bose method, dorsiflexion on the left and fixed distraction on the right. If you have to remove osteophytes, like these osteophytes, it's easy in dorsiflexion, but it's very difficult in distraction because you don't recognize the osteophytes. In dorsiflexion, you can recognize them and remove them. In distraction, it is almost impossible to remove them. For the gutters in dorsiflexion, you can go to the gutters, and here you see the medial gutter in dorsiflexion. This is the medial malleolus, this is the tip of the medial malleolus. It's fairly easy to go to the gutters. And also when you have to do a lateral ligament repair, arthroscopic, you cannot have a distraction because then the ligament is long, it's stretched, and you cannot shorten it. You have to go to a non-distracted position. So for the gutters and ligament repair, dorsiflexion is good, fixed distraction is not good. For assessment of the syndesmosis. So here the syndesmosis, to assess if it can widen, you cannot do it in distraction. There was this cadaver study. It makes sense that you cannot do it in distraction. You have to do it in without distraction. Loose bodies then. If you have loose bodies in the joint, here you see the loose bodies, it's easy to distract them in the dorsiflexion. With distraction, they will fall to the back of the joint. And then it's very difficult to remove them. And even if you remove an osteophyte, then the debris of the osteophyte can fall into the back of the joint. So the back of the joint is a sort of garbage bin for the ankle with loose bodies collecting there to remove them from the back. Osteochondral defect, we talked about it. Fixed distraction, obviously, it is great to work on the cartilage. But as I showed you earlier, with the hyperplantar flexion and some distraction and a combination, you can access as much cartilage as you can with distraction. Ergonomics. This is like you're sitting on a table and you're eating from your neighbor's plate. It's not good for your spine, not good for your neck. It's much more easy to eat from your own plate. So for the ergonomics, it is clear that this is better for the dorsiflexion versus. It works, yes. Thank you so much. Instrument breakage, that's also interesting because if you can move the joint, then the instrument can move with your movement, and it's not very likely that the instrument break. When you have fixed distraction, like in hip arthroscopy, you force your instrument around the corner and then it can easily break. And as to the complications, look here at the complications. Superficial peroneal nerve, twice more for fixed distraction. Sural nerve, 12 times more for fixed distraction. Saphenous nerve, 5 times more. Deep peroneal nerve, it is the similar complication rate. So the introduction, always in dorsiflexion, and in this narrative review that was published, ankle distraction method was routinely used in the past. However, nowadays anterior arthroscopy is done in dorsiflexion. Initially used as a diagnostic tool, ankle arthroscopy is now exclusively used as a therapeutic tool. So I believe the fixed distraction method should be abandoned. Okay, what can we do? Anterior impingement. The first prospective study we published with 5 to 8 year follow-up with 83% good excellent result for anterior impingement arthroscopic treatment. And we divided, here you see the percentage good excellent result 2 years, and here 5 to 8 years. The grade 0, it is soft tissue impingement. 1 is osteophyte without joint space narrowing. 2 is joint space narrowing with osteophyte. So this is an arthritic joint. So you see at 2 years, 50% for anterior impingement in an arthritic joint, but this remains over time. And for the grade 0 and 1, still 83% at 5 to 8 year follow-up. In a systematic review last year, the average success rate is still, in this systematic review of 1,500 patients, 81%. Average time to return to sport is 8 weeks. So excellent results in patients without joint space narrowing. What is interesting, and we showed that in our study already in 1997, that when we looked at the X-ray at a few years after the surgery, the osteophyte had returned in 70% of the cases. So if you remove this osteophyte, now it's removed, and you make an X-ray a few years later, the osteophyte has returned. And in this prospective study with 5 year follow-up, Walsh also showed that 84% of patients show recurrence of the osteophyte. Then this interesting study in 2018, a cadaver study, 670 cadavers, aged 20 to 40 years, so that's the age group in which you have anterior impingement. 20% had osteophytes. Isn't that interesting? So an osteophyte in the ankle is normal. So only remove osteophytes when they're symptomatic, and even if you remove them, they will return. So the pain is not from the osteophyte itself, it is of the soft tissue that gets squeezed between the osteophyte and the opposite side. And that's why we remove it in anterior impingement, because you have more space. And gradually the osteophyte will return, but only in maybe 5% in my series, 4 or 5% the complaints returned. So osteophyte is normal, don't remove them when they're not symptomatic. They will return anyway, and maybe you will induce symptoms. Osteophytes is an adaptive response to increase joint stability. A technical tip. If you remove osteophytes, how do you remove them? How much do you have to remove? Well, you could say they return anyway, so it doesn't matter how much you remove, but of course you will try to remove the complete osteophyte. And in order to do that, you go with your shaver above the osteophyte, it's always possible, to detect the distal tibia, and then you work your way towards the joint. And because you're in dorsiflexion, you cannot damage the cartilage. This is how you remove the osteophyte from the distal tibia. From the talus, likewise, you go in front of the talar osteophyte and work your way towards the joint. That's how you remove the osteophytes. What is interesting that I see a lot of patients who have been treated for anterior impingement and then they return for a second opinion because they have persisting complaints and often on the medial side. The medial osteophytes are often forgotten. This patient, for example, has a small osteophyte. So maybe you remove a small osteophyte here of the tibia, but this is the same patient with an oblique view and you see an osteophyte on the talus and an osteophyte on the distal tibia. And here you see an example of a CT scan. And even on the CT scan, it's not so easy to see what is osteophyte and what is not. But this is the osteophyte. I'll take it away again. If you look closer, you see that this is also osteophyte. You see from here, this is all osteophyte. And this ridge is osteophyte. So if you remove only this part, and that is often occurring, then you still have the osteophytes here. So maybe the range of motion increases slightly, but then you have more pain here on the medial side. So you always have to check when you're removing osteophytes to also remove the osteophytes on the medial side. Very important. And in order to do that, sometimes you need a third portal. So these are the standard portals for ankle arthroscopy, medial lateral. But in this case, to go to the medial malleolus, to go posterior, this is how you hold the scope. So the scope is in this medial portal, and you angle it viewing posterior, 30-degree posterior. So you see the tip of the medial malleolus, somewhere here. And then you put in a needle, you see here the needle, to make your portal, your additional portal. So you make the skin incision, you introduce your instrument, your shaver in this case. You see here the talus, this is the medial malleolus. I already resected here the bone from the anterior part, but now I work here on the tip and I can go really posterior. You have that space in between the talus and the deltoid ligament. For a 5.5 millimeter bone cutter shaver, you can take away ossicles on the tip of the, and osteophytes on the tip of the medial malleolus. We go to osteochondral defect. Osteochondral defect. It's important to realize that the ankle is the most congruent joint in the body. So that's why an ankle behaves different than, for example, a knee. And the pain comes from the bone. There's no nerve endings in the cartilage, the pain comes from the bone. And the cartilage is just there to protect the bone. So if you have a lesion, and you have a lesion in the subchondral bone, then the water from the cartilage is compressed on every step of walking into the subchondral bone, leading to water white on the MRI scan, and finally to cystic lesions. Cystic lesions you only find in congruent joints. So congruent joints. You don't find it in the knee joint, which is an incongruent joint. You find it in congruent joints like the hip joint and the ankle joint. And the process is like this. The water cannot go into the joint space. It has to go into the bone. And this raise in pressure on every step of walking is detected by the nerve endings in the bone. So when you look at the history, and I could have started earlier, but I start here with Statman, 1997. 1997, Statman published on microfracture for chondral defects, bone marrow stimulation. So he did it correct. He treated the bone. Yeah? Pain comes from the bone. He treated the bone. But then the research went into a different direction, went into making better cartilage, went into AC, MACI, AMIC, scaffolds, juvenile cartilage. So what has come out of it? What is the current evidence on the treatment of osteochondral defect in the ankle? These are the two latest systematic reviews. Systematic review in 2018 and the last one 2022. 52 studies, 55 studies. none of the intervention show clinical superiority. Isn't that amazing? 25 years of research, or maybe more, and when you look at the evidence, none of the interventions showed clinical superiority. And since bone marrow stimulation has a pooled success rate of 82, the pooled success rate of 82 suggests bone marrow stimulation as a fair treatment strategy for lesions up till 10 by 15 millimeter. So that is what the evidence currently is showing for osteochondral defects of the ankle. So what are orthopedic surgeons worldwide doing with osteochondral defects? We know from this study in 2021, an international survey among foot and ankle surgeons, 1,800 foot and ankle surgeons from 80 countries. For lesions of this size, bone marrow stimulation is the first treatment of choice for 80% of surgeons. So the evidence shows bone marrow stimulation, and that's also what orthopedic surgeons worldwide currently are doing. Of course, the question is always, what is the long-term outcome? The long-term outcome of bone marrow stimulation, and is there a critical size? Is 10 by 15 the critical size? Shall we not better add a matrix? What about the post-operative weight bearing? Direct, or should we wait for 6 weeks? And what is the average time to return to sport? And what about an MRI for follow-up? First, the long-term outcome, because you hear in conferences, John Kennedy from HSS often say, but we all know that bone marrow stimulation is only for a short period. We all know that it doesn't work on the long term. Well, let's look at the long-term outcome. We published in 2013 a long-term outcome in the JBDS, 80% good excellent result, joint space narrowing in 4%, 8 to 20-year follow-up. The three more recent studies, 10 to 12-year follow-up of microfracture, 93% survival rate, 86% return to sport. And this study by Jinwoo Lee, 97% survival rate, clinical result remains stable, 10 to 19-year follow-up. Joint space narrowing, same as we had many years ago, it's about 4%. And also this literary review confirmed that the results remain over time with joint space narrowing of 4%, which of course is not good, but will it be better with other methods? We don't know. We only know from bone marrow stimulation there's long-term follow-up studies. I don't believe it will be better with other treatments, but we don't know. Then the critical size. We know from those two studies in 2009 and 2008 by Jinwoo Lee and Chuk-Pai Pong, they determined this critical size of 10 by 15. So bone marrow stimulation is for lesions up to 10 by 15 millimeter. Then the group of John Kennedy in 2017 did a systematic review, and they included 25 studies with 1,800 ankles, and they concluded that bone marrow stimulation may best reserved for lesions up till 107 square millimeter, which is, for example, 7 by 15, or 8 by 13, or 9 by 12 millimeter. However, the study on which the results on which they based their conclusion, 24 of the 25 had a not good methodology and a poor level of evidence. So the evidence on which they based their conclusion is very poor. And then came the study from Jinwoo Lee, bone marrow stimulation in 202 ankles with long-term follow-up, no difference in VAS and AO VAS between the smaller and the larger lesions, between shoulder lesions and contained lesions, between cystic and non-cystic lesions. Survival rate of 97% for the smaller lesions, 83% for the larger lesions. So what does the average orthopedic surgeon do in the world with these larger lesions? Well, from this survey, which I just showed you in 2021, also for these larger lesions, bone marrow stimulation is the treatment performed most frequent. It doesn't say that it's the best treatment, but when you look at your colleagues, they will still, for the larger lesions, also do bone marrow stimulation. So it's very interesting. So you don't have to be scared that if you do in a larger lesion a bone marrow stimulation, because there's no other option in your vision, then you're backed up with your colleagues. So shall we not better add a matrix? That was in Britberg in 1994, came for the first time with cultured chondrocytes. And you all know that. And you all know the studies of Engebretsen, I assume, who compared ACI with microfracture in the knee, 2-year follow-up, midterm follow-up, long-term follow-up, and in all cohorts, there was no difference. And even in the long-term cohort, there were twice more total knee prostheses in the ACI group than the microfracture group. And when we look at the ankle, the most recent studies since 2018, you see that there is no benefit, which comes also out of the systematic reviews of adding a matrix, adding chondrocytes when compared to microfracture. And for example, Christoph Becker, they stopped with AMIC after they published, they analyzed their results of 5-year follow-up in which there was no difference. Early weight bearing or not. There has been this systematic review and meta-analysis in 2021, 5 randomized clinical trials, and there were comparable clinical outcomes of direct postoperative weight bearing, that is at 2 weeks, 1 or 2 weeks, or wait 6 weeks. Same is for the knee, so it has not been shown that delaying weight bearing after microfracturing gives better results. Time to return to competition after bone marrow stimulation, average 5 months, and that's also my what I tell my patients, to wait for 5 months to return to sport. In athletes, you go back earlier. In athletes, you take a risk. They have a shorter lifespan for their profession. So usually at 3 months, they go back. But for the average patient, it's advised to wait 5 months to go back to sport. Then two interesting studies. That showed, and here you see one of them, that after microfracturing, the result improve, clinical result, up till 2 years after the surgery. You see here the average FAS score preoperative at 3 months, it's better. At 6 months, better, 2.5. 9 months improvement, 12 months improvement, 2 years improvement, and then it stabilizes. And for the AOFAS, similar. So it means that if you have a patient with bone marrow stimulation that comes to you at 1 year and that still has some complaints, you can explain him that he can expect to be better still till 2 years. I think it's an important, and it's also my experience that the cartilage will mature and it will get better up till 2 years. So how and why does it work? Why does bone marrow stimulation work? Pain comes from the bone. The cartilage is just there to protect the bone. Ankle joint is the most congruent. It's the edge of the defect which takes the peak load. I want to introduce to you this concept of edge loading. I think it's important for every treatment that you do to think about this concept of edge loading. What do I mean? We have an osteochondral defect here on the right. We take it away, it will fill with fibrocartilage, blood clot, fibrocartilage. The subchondral bone plate will restore. fibrocartilage on top, and we have a good result in 90% of cases. With a large defect, initially happens the same. It will fill with a blood clot. But now, it's the edge of the defect which takes the load, not the defect itself. I mean, there's also some load on the defect, but there's more load on the edge of the defect because the filling is not as stable as the edge of the defect. So that's where the load is coming. And if the load is too high in a large defect, then this will lead to a new cystic lesion. And you see in this case, the cystic lesion is not under the original defect, it is under the edge of the defect. And if this continues, it will go to an arthritic joint and a varus arthritic joint like this. So the objective of any treatment is to provide the defect with a filling that is capable of taking the load on the edge of the defect away. And in most cases, microfracturing can do it. But in a larger defect, it gets more and more difficult. And that's why, for example, these metal implants came on the market some 20 years ago. We published the 5 years follow-up of the first generation implant with a 94% survival rate. And if you implant it, you have to implant it below the surface because the cartilage compresses. So this is what happens on walking. So in this case, it takes away the load of the edge. Now we have the second generation implant, which is personalized, which I believe is an improvement to this implant. Next topic. Arthroscopic evaluation in fractures and instability. Most patients with a fracture, or a lot of patients, are instability when you do a ligament reconstruction, you do also an arthroscopy. And in fractures that is also being done, and it comes from this article from Hintermann in 2000, because he showed that in 288 patients, 80% had cartilage lesions in a fracture. So in any ankle fracture, you have a high chance of cartilage lesion. And that was the basis of doing arthroscopy when you fix an ankle fracture, to do also an arthroscopy. However, in 2019, there was this publication from Kennedy from a database with 30,000 ankle fractures. And only in 1%, American surgeons, only in 1% do arthroscopy when they fix an ankle fracture. Only 1%. And there was no significant difference in reoperation rate between the two groups. And this review, systematic review, again showed no difference in clinical outcome if you do an arthroscopy in a fracture, yes or no. So doing an arthroscopy in a fracture has no added clinical value in these patients. What about instability? From the same group, Hintermann, arthroscopic findings in patients with chronic ankle instability, 66% of ankles have cartilage damage. So that was the start for all of us to do ankle arthroscopy before you stabilize your ankle. However, 2017, similar reoperation rates with or without traditional arthroscopy during ligament repair, 8,000 patients. So also in instability, doing an arthroscopy, diagnostic arthroscopy, is not useful. Of course, if there is a clinical impingement or there's an osteochondral defect that you want to treat, that's another thing. So there's no place for diagnostic arthroscopy. And that's what we already published in 1997. No indication for diagnostic arthroscopy. No indication for arthroscopy in ankle fractures. So in the Smith and Nephew guide, which tells us that we have to do a 21-point examination with any ankle arthroscopy, I don't believe that that should be done. Because, for example, you do a diagnostic arthroscopy and you see those tram lines, those tram tracks. What do you tell the patient? The patient is very worried. He sees this during the surgery, and what do you say? You say, yeah, what do you say? I mean, you're not going to treat it, and the patient will be worried that there is cartilage damage. So you better not know that there is this cartilage damage. It's superficial, and you're not going to treat it. You cannot treat it, and you should not treat it, because it's not symptomatic. It doesn't go through the subchondral bone. It's just superficial scratches in the cartilage. So better not know, because you only will worry your patient. And even with those asymptomatic osteophytes, I mean, you can remove them, but as we learned earlier, they will return. So just treat the symptoms and don't treat what you diagnose by an ankle arthroscopy, by diagnostic ankle arthroscopy. And I know by treating high-level athletes that there is hardly any soccer player without some changes in the ankle joints, without complaints. So often they have multiple changes, like cartilage lesions, like osteophyte, like some synovitis, ossicles, and it's only when they become symptomatic, it's up to us to see what is causing the symptoms, and not to treat all what we see during the arthroscopy. It will only induce some scar tissue formation and maybe some limitation of motion. Just treat what is needed. What's the time? 8:35. We still have time, huh? Okay, we continue. Instability, very important, instability. What I find important, and I hope that you take away, that's one of the takeaway messages for today, is to distinguish laxity from instability. Laxity is a sign, it's objective. It's, for example, an anterior drawer. Instability is a symptom, it's subjective, it's recurrent giving way. So as we sit here, a lot of us will have laxity. Yeah, if I would test your ankles, there will be 4 or 5 who have laxity, but you don't have symptoms, you don't have instability. So we're not going to treat you. We're not going to treat all those lax ankles. We treat instability, we treat a patient who comes with symptoms, with complaints of recurrent giving way. And you can divide it in functional instability, which is recurrent giving way, and you test the ankle and it's not lax. It's a stable ankle, but the patient is giving way. Happens very, very often. Or mechanical instability. The patient is giving way, you test it, and it's lax. I think it's really important to distinguish this. And the question in mechanical instability is, what is better, open or arthroscopic repair? Is repair of the ATFL enough? Because arthroscopically we can only do the ATFL, we cannot do the CFL. If we do open, we do both. But we cannot really do that arthroscopically. Only for a very happy few who say that they can do it, but that's not easy. So is ATFL repair enough? Augmentation with the retinaculum, the gold procedure, is it needed? Is it better? Augmentation with an internal brace, is it better? What if there's no remnant of the ATFL? And diagnostic arthroscopy, we already mentioned it. So first, open or arthroscopic repair. It started with Corterial in 2009, and then Jordi Vega popularized the arthroscopic repair in 2013. So what's the current evidence? There have been 4 meta-analyses, 18, 19, 20, and the last one in 21. The ones in 2018 and 2019, no difference between arthroscopic versus open repair. However, in the 2020 and 2021, significant difference in favor of arthroscopic repair with regard to AOFAS and FAS score, higher AOFAS and Carlson score, lower FAS pain score, lower wound complication, and similar stability for arthroscopic repair. So at this moment in time, based on the literature, we have to conclude that arthroscopic repair gives better clinical outcomes and that there is a good indication to switch to arthroscopic treatment of chronic instability. Is ATFL repair enough? We published in 2005 the long-term result with reconstruction of only the ATFL. So we were used to only doing the ATFL. But then when I was discussing this with John Carlson in conferences, he said, yeah, but if you open it and it's a long-standing instability, the CFL is also lax. So why not do both? It makes sense to do both. So I agreed. So since then, even though we had a good result with only ATFL, I also repaired ATFL and CFL. But now with the arthroscopic, we can only do the ATFL. So how does the ATFL only do? 2020, no difference between ATFL plus CFL or only ATFL repair. And what I think is important to realize and to use during your arthroscopic repair is that there is always, never say always, but that there's always connection between the ATFL and CFL. It is one ligament which attaches to the fibula. So if you attach it here, you can take it down as one flap. Yeah, that's also what I do in open. Because if you in open, if you take away the ATFL separately and separately the CFL, ATFL you can put back, but the CFL is very difficult as an isolated ligament to put back. But it's very easy if you take it as one flap, because then this flap you can easily put it up. Yeah? And bring it to the fibula. And that's also what you can do in your arthroscopy. Because if you take it down and you take only the ATFL and you bring it up, then you also shorten the CFL. And that's probably why the arthroscopic still works, because you shorten the CFL simultaneously if you just bring up the insertion of your ATFL on the fibula. The Gold procedure, this is the retinaculum, and Gold told us you can take the retinaculum and bring it to the fibula. That was in 1980. In 2021, there were 3 studies, no difference in outcome with or without the Gold procedure. So apparently it is not needed. And it makes sense that it's not needed, because if you look at the cadaver, if you do a cadaver study, then technically it's not possible. It's not possible to isolate the retinaculum and bring it to the fibula. It is more the soft tissue that's in the area that you bring. You cannot bring it. And even if you can bring it, it is not in the right direction. It should be in this direction, the fibers. It is in this direction. And it's not a ligament. So it's not ligament fibers. So it does not make sense, and it's technically not possible to add a rostrum. What about the internal brace? Internal brace, introduced in 2016. Systematic review in 2021. 7 clinical trials were included. Conclusion, no major difference regarding clinical, radiological outcomes or complications. Microinstability. Shall we skip it or shall we do it? Go for it. Microinstability, a hot topic. It was introduced in 2016 by Jordi Vega. Microinstability as a cause of anterolateral pain after an ankle sprain. And he wrote, despite no abnormal laxity, so the patient is not lax, but has changes to the ATFL, functional instability and anterolateral pain. So it were patients with anterolateral pain, so impingement pain, with some giving way, stable ankle, and some changes to the ATFL. And he called it microinstability. But then in 2021, a few years later, in a 4-year period, 232 patients with microinstability were reviewed and treated. I don't think in my career I operated 230 patients with real instability. So 230 patients with microinstability, that's a lot. And now the definition has also changed, because now there is a subtle anterior translation and mechanical laxity. However, if we look at what is a normal ankle, 0 to 2 millimeter is a normal laxity. So basically, he calls it microlaxity, but basically it should be functional instability with morphologic changes to the ATFL. I think that would be a better description of what he is treating. But how many patients do have morphologic changes to the ATFL? In USA, there's 10,000 ankle ligament ruptures each day. 30% have persisting symptoms, so that's more than 1 million per year with potential microinstability. So then 230 is not so many. That's just a start. So that's the wave that is coming, and I didn't understand it when I read the editorial, but now I understand the wave that is coming. So the takeaway on instability. Functional instability needs conservative treatment, because if the ankle is not lax, you cannot make it more stable. If you treat an ankle ligament which is not too long, you make it too short. Yeah? So those patients with microinstability, if you do a repair, you make it too short. And what happens if you make it too short? You induce a plantar flexion limitation. So functional instability, long conservative treatment. In case of persisting pain, that's originally how he was treating microinstability, it was soft tissue impingement, do a synovectomy, but don't do or even a capsular shrinkage, but don't do a repair. For mild and moderate laxity, the all-inside arthroscopic repair, and you can find it on the ankle platform, the Jordi Vega technique. And what about long-standing laxity, gross laxity, a heavy patient, professional athlete? In those cases, how I do it still is open. So I take off the ATFL and CFL, put a suture through the ATFL, put a suture through the CFL, and then bring it to the fibula. Next topic, ankle arthrodesis. Interestingly enough, the first comparison of arthroscopic and open was by Meyerson. Meyerson is not an arthroscopist, he is against arthroscopy. So it was not a surprise that in this review, open approach was better than the arthroscopic. That was the first publication on ankle arthrodesis. Systematic review and meta-analysis in 2020. Arthroscopic arthrodesis, higher fusion rate, smaller blood loss, shorter tourniquet time. And a systematic review and meta-analysis 1 year later, shorter fusion rate and less complications. Okay, so arthroscopic seems better than open. And we published that you can also do it from the back, posterior arthroscopy, and this run home screws, because all those have been done from the front, and we published in 2016 already fusion from the back. But then let's look at the Swedish registry. 2018, Swedish ankle registry, 130 re-arthrodesis in primary arthrodesis from the Swedish ankle registry. And here you see the method of fixation. And look, arthroscopic screws, 14% re-arthrodesis rate. So these are not from high volume centers, this is from Swedish orthopedic surgeons. Yeah? Arthroscopic screws, open screws, 8%. Plate and screws, only 3%. Isn't that interesting? I mean, with the arthroscopic, of course, you can easily take away the cartilage, but it's the screw placement that is important. And apparently, with the open screws, you can place it better, you see what you get, than with the arthroscopic screws. So that's what you can learn from this, that your screw placement is very, very important. So it doesn't have a higher fusion rate in the hand of average orthopedic surgeon. Maybe you have to do it from the back. We had 100% fusion rate. Okay, that's only one series, so that's not enough, but something to consider. The two-portal hindfoot approach, we introduced it in 2000. We will show it in the patients today. One of the patients, we will do a subtalar arthrodesis, yes, show. If we look at the meta-analysis in 2021, complications significantly lower with the endoscopic treatment. Time to return to previous sport, 12 weeks for open, 7 weeks for scopic. Complication rate, 23% for open, 4% for arthroscopic. Excellent results in ballet dancers and in athletes. If you look at the complication rate for hindfoot endoscopy, it's only 2.3%. And in this review was confirmed that it's indeed 3%. And what's interesting to realize, the most common complication is Achilles tightness. So don't remove too much soft tissue when you do your posterior arthroscopy, and don't put your portals too close to the Achilles tendon, because if you touch the Achilles tendon, then probably this will lead to Achilles tendon tightness. We were always afraid of damaging the tibial nerve, and of course sometimes it happens, but apparently when we look at this review, that's not the case. And what's interesting also is to look at the systematic review on endoscopic tarsal tunnel release. So if there is a compression of the tibial nerve, you can release it. There are 4 studies, there were no complications and a 95% success rate. So that's interesting. Tarsal tunnel syndrome, do an endoscopic release of the tibial nerve. I was also interested in the learning curve, because you always hear, yeah, but it's difficult, posterior arthroscopy, is there a learning curve? There's 2 publications on it, 2018 and 2021. Operating time for arthroscopic ostragonum resection decreased by 25% when cases doubled. So yes, there is a learning curve, but not that much. An experience of 26 cases was required to be proficient in posterior arthroscopies. No difference in postoperative AOFA score between the initial and the latest 10 series each. So, not so bad. Fusion, subtalar fusion. First published by Lundin in 1994. Testo from the lateral side said it was technically demanding, and we published this 3-portal approach from posterior, and then this topical review in 2021. Excellent union rates of average 96% at an average union time of 8.8 weeks. So, excellent procedure. Arthroscopic arthrolysis. I think it's interesting because it's something which is, I think, forgotten. At least I have been forgotten it for quite some time. But it was already published in 2006, Arthroscopic Management of Frozen Ankle. 2008, arthroscopic release for stiffness after calcaneal fracture. After calcaneal fracture, subtalar joint is stiff, And you can do a release, arthroscopic release of the subtalar joint with a clear improvement, as you see from this study. So that's something to think about before maybe go for subtalar arthrodesis. If there's stiffness, you can consider a release. And this is also interesting. Second look arthroscopy for after ankle fracture. Second look arthroscopy for arthrofibrosis after ankle fracture can improve clinical outcomes. And that's what I learned from my Helder Pereira when I was operating with him in Porto. He said, yeah, these older women with their ankle fractures, they always are stiff and have some complaints. And I often do arthroscopic release. Well, it's something to consider after an ankle fracture. So to conclude, the evolution went from skeletal distraction to fixed soft tissue distraction, and currently the dorsiflexion method. Anterior ankle impingement, 81% good excellent results. Taylor OCD, bone marrow stimulation is the first line treatment, and the results remain over time, and it's the treatment of choice for 80% of surgeons. For chronic ankle instability, arthroscopic repair is the best choice currently. Micro instability should be called functional instability with morphologic changes to the ATFL, and treatment must be conservative for at least 1 year. Arthroscopic ankle arthrodesis has several advantages, but screw placement is key. Subtalar arthroscopic arthrodesis by a two-portal hindfoot approach gives excellent union rates in average 8 weeks. The two-portal hindfoot approach for a variety of indications is better than open. Endoscopic calcaneoplasty, I took it out because we will still, I have a separate presentation, that's why I took it out of this one. But I can already tell you that it's better than open. Endoscopic treatment for Achilles tendinopathy, also better than open, will also be in the other presentation. No fixed distraction, no diagnostic arthroscopy, no 21-point examination. Treat the patient, not his MRI. Listen to the patient is always right. And that's it. This is, I think, Ipanema Beach, and yeah, I think this is Ipanema Beach, and this is Copacabana. Oh, where is it? It's gone. Can we have back this important last slide? Can you bring back the last slide, please? That's Ipanema, and this is Copacabana, no? Yeah, because I think there are 32 beaches in 32 beaches in Rio. I learned. it's good.
We have time for some questions.
Nikki, thank you very much. It was an outstanding presentation. Really, it's fantastic seeing someone like you have this brilliant talk. And I would like to know, what are your thoughts about Masato Takao's reconstruction, fully arthroscopic reconstructions of both anterior tibiofibular and calcaneofibular ligaments? It's not like a repair, it's a true reconstruction. What do you think about it?
Yeah, you can do it percutaneous or open, or even semi-arthroscopic, I believe. Yeah, and he takes the tendon. I think what tendon does he take? I think a hamstring,
Yeah,
and he makes this nice configuration. It looks really nice, and I think it looks. If you place it correctly, I think it looks really good. Question is, do you need it? In the sense that it's not easy to perform. Let's say it like this. I was in a discussion in another conference with John Carlson, and we were talking about chronic ankle instability, secondary procedures. So you have because this is a procedure that you do after a failed primary procedure, because you will never do this as a primary procedure, the Takao procedure, because you can always do an anatomic repair, always. In my 40-year career, I have never had a patient with a primary procedure in which there was no remnants to bring to the fibula, because any rupture will always heal, primary rupture, but it's too long, right? So the ligament is too long, but you will never in a chronic case have two separate ligaments, like a ruptured ligament. I mean, there's always a ligament that you can always shorten. So I've never needed to do a tendon graft. Okay, that's for the primary procedures. But then for the secondary procedure, so when the first failed, or I have a patient that was operated somewhere else, I also do Brostrom. And I confessed at that conference, it was not so long ago, that I hardly ever, maybe even, no, never say never, do tendon reconstruction. I always do a second Brostrom. If the alignment is not good, then I will add a calcaneal osteotomy. So I have a calcaneal osteotomy. So in a secondary procedure, I will look at the alignment, and then I will see if the alignment is like varus. Then I do a lateral shift calcaneal osteotomy, and I do another Brostrom repair. And especially when the patient comes from someone else, so I didn't do the first surgery, then they forgot to do the CFL. So then you have to really look at the CFL and put up the CFL and the ATFL. So in my patients, I always come with, or the solution is always a Brostrom type of procedure. And if I would have to do a tendon, then I take the plantaris tendon and make the ATFL, not the CFL. So theoretically, it's a nice procedure. It's a lot of work. The room for error is there. I will never use it.
Thank you very much.
Alguém quer perguntar mais alguma coisa? Pode perguntar em português se quiser também, que tem o tradutor aqui.
Thanks for the excellent talk, Dr. Nick. Do you feel any indication for internal brace in your practice?
Yeah, that's a good question, because if you look at the evidence, then you say, well, there is no added value. But looking at the evidence doesn't mean that there's no indication, because it is just in series that it's like with the arthroscopic treatment is better than open. When you look at the meta-analysis, I still prefer the open in most cases, because it's a fantastic procedure. And with the arthroscopic, I'm sure that when we look at 10 years from now, that the open there will be a revival of the open, because the arthroscopic is industry driven, it is surgeon driven, it's a new thing. So there's studies, and then the pendulum swings to the arthroscopic. And you see it with a lot of procedures that, and we can talk about it this afternoon, Achilles tendon ruptures. We went to minimal invasive. When you now look at the evidence, the open is better. We can talk about it later, but it is when there is some new devices, then almost always you get some publications who go into that direction. But for the internal brace, it's not per se that is bad. And I believe if you have a heavy patient, American football player, a heavy patient, or a high profile patient, no, not a high profile patient, heavy patients, and you have done not a really good repair, so the tissue is not that you think, well, this is really a good repair, then it's a cover-up for your procedure, because it helps you to stabilize it. If you don't make it too tight, because if you make it too tight, you induce range of motion deficit. So you have not to make it too tight, better make it a little bit loose, but it helps to protect your reconstruction. So I think in those patients, heavy patient, maybe athletes. I'm a bit reluctant to say athletes. But for example, for Neymar, I would have probably done it. I think he would be the only athlete with such a thing that I think that I would have considered it. Maybe he got it even. Yeah, so there is an indication in those patients, I think.
And for hyperlaxity patients, do you think it's a good indication as well?
I have treated hyperlax patients, and I always thought, what am I doing? Because it will be lax again, because the material is not good. I have only done anatomic reconstructions also in those patients with good results.
The same thing as they were not hyperlaxed.
Yeah, exactly. The same as they were not hyperlax. Yeah.
Thank you.
Okay, thank you. Let's
Question?
go to the surgeries.
You don't have a question?
I have a question,
that's
but okay. Some people say that the ankle, the tibial osteophyte, if you remove it, you can lead to instability. How do you deal with this in patients with impingement?
Yeah, that's a very good question. And because the osteophytes stabilize the ankle. I mean, that 20% of us have osteophytes, or probably our age, even a little bit more. So they stabilize the ankle. So if you take it away, it tends to be a little bit more lax. So if you already have a laxity, the osteophyte will help you to make it stable. So if you have a lax ankle and you have an anterior impingement, but you have no instability, so the patient doesn't give way, but he is lax and he has osteophyte. You're going to take away the osteophyte, he will be more lax. So then he might become unstable. He might become. So that is the indication to consider an arthroscopic repair. Yeah, that's the indication to talk with the patient, to discuss this and say, well, we might consider doing this because you are lax and you show that he's lax and you might get symptoms of it, etc. It's a very good question and a real something to discuss with the patient. Yeah.
Nice.
Yeah, nice.
Thank you.
Yeah, Dr. Van Dijk, thank you. Thank you very much for your talk. I will keep in the same way. When we are removing an osteophyte, that is something that is result of an arthritic change and some kind of instability. The arthritic joint is trying to be stable, and we know that it's going to come back, and those articulations are often stable. Do you look for and even repair, knowing that they are coming back, any instability?
No, because they come back. So the ones that, in the two studies that show that the osteophytes come back, in 80% of cases, they were not lax. So they come back anyway. So there's an imprint in the body or whatever that this osteophyte comes back. What's interesting if you have an arthritic patient, so you have a patient, he comes to you, he has pain in the front of the ankle, he says, I have superficial pain, and you palpate, and he says, yeah, this is my pain, in the front of the joint, you make an x-ray, and he has an arthritic joint with osteophytes. Then he has a 50% chance, if you take away the osteophytes, that he has a good result, only 50%. We know that from the studies. So you tell the patient, well, we can do an arthroscopy, and you have a 50% chance. He said, well, the 50% is not good enough. What's the alternative? You say, well, we can do an arthrodesis or a prosthesis. And so, no, give me the arthroscopy. And so if you explain to the patient that he has a 50% chance of becoming better, but that the alternative is what I'm just saying, then most of your patients, even the ones that do not benefit 100%, will still be happy. Well, happy, but so I think that's important to maybe also tell them that the osteophytes come back, also in a normal impingement patient, that the osteophytes come back, but that the chance that the complaints come back within 8 to 10 years is only 5%.
Thank you. And in your experience, do you think that the bone spurs are a personal change or some instability change?
That does?
Do you think that the bone spurs are inherited something for the unstable articulation or something about the personal features of the patient?
Yeah, I didn't, but when I was looking through the literature, I took it out of the slides. But patients with chronic instability, in 31% have osteophytes. So in normal population is 20%, but that is in the cadaver study. Patient with chronic instability, 31 have osteophytes, and patients with osteochondral defects, almost 50%. So osteochondral defect is more a driver in the body, apparently, to stabilize the ankle, get less motion because of the osteophyte, than instability. But instability itself also is a driver for making the ankle more stable. Yeah, so I think the osteophyte is just an adaptive response of the body to limit the motion of the joint in order to protect an osteochondral defect or a laxity, or it's a natural. So if you take it away, you take away that defense that the body made itself. So then you have to do something else, like treat the osteochondral defect or treat the instability. And even then, osteophyte will return.
Okay, thank you. Let's go to the OR.